from writing down all the quotations I heard from Ron and Lee. We're going to dispense with introductions. I think don't we have a slide that shows everybody's name and title, which should be coming up pretty, yeah, so we don't have to re-recite that. We're going to jump right in. Michael Neuss. Michael, you're the CMO, Chief Medical Officer at Vanderbilt-Ingram. Before we get into any specifics about models per se, how satisfied are you that we're getting greater value out of oncology care today? Is there any direction to this at all? Are we getting more value or are we not getting more value, Michael?
Well, thanks, Cliff, for asking the question, and thanks to my friends Lee and Ron for their presentations and their work on developing new models. We are making progress. Lee did not mention some of the important work he did where he paid doctors differently. He discounted that and said changing the model of payment might not be effective. And Ron's program, which is much more complicated, has really changed the way we take care of patients now. But I think the key to both of them, and the place where we haven't made as much progress as we could have, is in measurement. What Lee showed us with his only slide was that having a visual, having an understanding of the costs associated with care broken down by different categories of patients was really how we were going to identify best practices, move forward, and approach this. And it is inexcusable and incomprehensible that with the EMRs we have now, we can't get our arms around these data easily.
So we're not going to know if we're accruing greater value without those data, correct?
That's correct.
Lee provided some early looks at some of those data, and I think he made his opinion clear about that. Daniel Mirda, you're the president of the Association of Northern California Oncologists. You're one of those people on the ground and so forth. Are we or are we not getting greater value out of our oncology care delivery today?
Well, it's very clear that the demands on the community oncologists, the university oncologists, have just skyrocketed. We have availability of a lot of new agents, and they're increasing at a much more accelerated rate. I think that almost everyone who practices oncology now and takes care of patients sees that value is really what we want to be able to provide. I think there's a lot of controversy about that we haven't provided value up to now, and that really is kind of a challenge. But I think that there's a lot more realization that the landscape is much more complex with EHRs, which actually most oncologists practicing tend to feel this is interfering with the value we provide. And really now people are much more concerned about financial toxicity. Unfortunately, I think to Lee's point, that the tools that the average oncologist has to be able to understand cost for their patients is happening on the ground level. I have so many patients now that come back to me with, they can't afford the drugs that they're currently taking. We cannot afford by the copay. We're not even talking about the total cost. Even when their insurance covers it, their copay is insurmountable. So I think we're all becoming much more aware of helping our patients at the very basic level of financial, and then having all these drugs available at the right times, and we'll get into more of that granularity, but these are major issues that every oncologist, I think, even in universities, where they were somewhat immune in the past to this cost issue, now I think it's ubiquitous among all oncology, and I can't tell you members that come to us in the difficulties of co-payments, and also the difficulties of dealing with the insurers has become somewhat more challenging in terms of peer-to-peer reviews, which I think is a common theme now, that we're oftentimes trying to justify what we want to do, and not all the boxes have been checked.
David, you talked about the patients a moment ago. Are patients seeking or receiving less care or less than optimal care because of financial toxicity in your direct experience?
I think all of us in the audience who practice now are really seeing the patients are coming to me and saying, I cannot afford this therapy. What are my other choices? And when we try, and really at the ground level, all of us want to give patients the best option. And unfortunately, sometimes that best option is the most expensive option, and we have to look for second choices that are less expensive. And the example brought up of like Gleevec, which you would think would be a good second choice compared to more expensive second generation drugs. It's not always the case.
Okay, so financial toxicity may in fact translate into or lead to lower access, suboptimal medical care, and perhaps suboptimal outcomes, to use these terms.
We're very careful about suboptimal care because we talk about value. And the question we brought up in our early discussion this morning is how we're going to judge value is also going to be a very important point.
Well, you mentioned the insurers. Let's go to the insurer here, Dr. Bhuvana Sagar. Bhuvana, Cigna is a pretty big healthcare payer, and you're about to get bigger with some very interesting vertical integration that's in the news a lot that might give you a little bit more leverage if this deal with the PBM goes through. From your standpoint as one of the major payers in the country, are you seeing greater value being derived from oncology care or less these days? Where are we headed now?
I think to step back a little, fundamentally, I think we've changed the way payers are interacting with providers. I think it's more collaborative. I think we're working towards a common goal of improving outcomes, quality of care. I think these are things that were not as much in the discussion in the past. I think we're talking with leaders about how do we actually go about doing this. That being said, I think overall we're driving value. I think we've had a few collaborations with a few major leaders in the provider space, and we think that we're moving in the right direction. Overall, it's a positive improvement in decreasing inpatient utilization and decreasing ER utilization, early palliative care use. So we've seen a lot of positive changes clinically, but we also recognize that it is an iterative process, like Lee talked about earlier. We need to look at how do we address the continuum of population. It's not just to be limited to large provider groups. I don't think the outcome, the improving outcome and improving quality needs to be spread across in general. So that's what we're looking at. How do we address smaller volumes which contribute to increasing cost? Because smaller volumes traditionally have increased volatility. So we are trying to address that dynamic as well.
Bhuvana, are you able to track from the standpoint of being one of the country's largest payers, do you have the data with which to track improvements in value, whether it's better financial management, better access, improved outcomes? Do you have enough data to know what you're paying for?
So we're actually working on that. We have a portal used where we're collecting the clinical data. And with the clinical data, we're trying to tie it to claims, and we're trying to analyze the information to get more with it. Like Lee talked about, the data registry is very helpful. OCM has a data registry. I don't think we had enough clinical detail in the past. And oncology is very complex, very heterogeneous. Not all breast cancer is breast cancer. We all know that. So you have to have that level of granularity to be able to get to that, what you're talking about, and we're still working on that.
Is it also true for you, as Dr. Newcomer said, that if a cancer drug is approved by the FDA and it is ordered or prescribed, you got nothing to say about it?
Correct.
Okay.
We follow the FDA and the NCCN guidelines. We have not limited our options. I know several payers have done that. There are a lot of pathways, that are in place. We've tried to stick with the NCCN guidelines, category 1 and 2A and 2B, but we are doing what we feel is right for our customers. But on the downside, we do want the providers to look at the value. How many weeks of survival are they getting, and at what cost? We do want the providers to have that.
Got it. Thanks very much, Dr. Sagar. Travis Bray, just tell us ever so briefly what it is the Hereditary Colon Cancer Foundation you founded. What is it briefly, Travis?
Our stick is trying to actually reduce the number of cancer survivors by increasing the amount of providership, being a spokesperson for prevention of cancer.
Okay. From the standpoint of a patient rep in an advocacy group, Are you seeing us derive greater value out of the cancer care system these days? Where are we headed from your standpoint?
I like what Dr. Newcomer was talking about, general insolvency for patients with cancer. I mean, over the last, there was an article that just came out that said that 78% of cancer survivors deal with people being treated with cancer patients are being, report moderate to catastrophic financial burden, and that's continuing to go up. But in the last, in my research for this panel, in the last 8 years, all the payers' stock margin's gone from $25 a share to $225 a share. So there's a bunch of money going in one direction, coming from someone else. And I think it's going to maintain that direction. One of the strongest lobbies in America is the pharmaceutical lobby, and that's driving this kind of style of care and changing the conversation to survivorship and pushing it away from credible ways to prevent cancer, which if there was 1.6 million people in 2016 that had cancer, 10% of that was genetic. Every one of the payers here, or actually CMS, requires that people with a genetic form of cancer or have a family history of cancer actually have cancer before undergoing genetic testing that can prevent cancer.